Thank you very much for giving me the chance to present my research. I'm honored too. Maybe next time I'll see you in Seoul. But for now, today I'm going to talk to you about the effects of biological sex in brain disorders. And I'll present research that I made in the last few years with students in Trinity College, Dublin. Okay. So for many years, we have studied brain disorders, taking into account many factors like synaptic plasticity, metabolism. But up to now, and I would say the last decades, the biological variable has been ignored. And this has been presented by a study done a few years ago by Duffy and Epperson, which in brain disorders, they examined 15 studies, and they considered how males and females were considered separately in these studies and how the biological variable was properly investigated. And they find that only 50 of these 15 studies correctly included males and females and considered the variable. So this shows that the biological variable has been ignored pretty much during the last years. And this factor has been considered also by NIH, who demanded that all the studies funded with NIH funding would be required to specifically acknowledge the differences between males and females. And so far, even if this announcement of the NIH was done 10 years ago, this has not been respected. Not only this, also in FDA-approved studies, although in principle they are enrolled both males and females patients, the actual number of females is 20-25% of all the patients. So in general, both clinical and preclinical, there is a tendency to enroll males. And this is mostly because of the greater variability that we find in females. One of the big differences is, of course, at the hormonal level. As you can see, the hormonal level in females peaks at the age of 30, 40 years and then declines quickly with menopause. For male, the situation is different because testosterone peaks at around 20 years and then slowly goes down over the years. Not only this, but females also have fluctuations of hormones during their fertile period. In fact, because of the menstrual cycle continuously goes up and down. So hormones are very important, as we will see in the next slides, because they actually affect both neurodevelopment but also neurodegeneration. So it's important to consider hormonal levels when considering brain disorders. But they're not the only factors influencing the brain disorders. So other factors are genetic factors, environmental factors, and sociocultural factors. For the genetic factors, it's easy to think that a sex bias could come in genes that are expressed on the X chromosome, because, of course, the females have two X chromosomes, and while males have only one. So if a mutation happens on an X-linked gene, in males, the mutation will be more severe. However, many genetic factors that influence the onset and progression of brain disorders are not necessarily located on the X chromosome, although many are. Environmental factors include several factors, but one of the main factors is linked to maternal infection during pregnancy, which has shown to increase the frequency of autism and other disorders in the offspring. And last but not least, there are socio-cultural factors which influence both the diagnosis, but also the tendency of patients to present symptoms. So a few years ago, with some talented students in Trinity College, we decided to research what was the situation in 3 neurological disorders and 3 psychiatric disorders regarding the studies that were presented for the disorders, both at the clinical and preclinical level. And we chose to look at Alzheimer's disease, Parkinson's disease, and amyotrophic lateral sclerosis for the neurological disorder. And then we looked at depression, attention deficit, hyperactivity disorder, and schizophrenia for the psychiatric disorders. Now, Alzheimer's disease and depression are mostly present in women. On the contrary, Parkinson's disease, attention deficit, hyperactivity disorder, and amyotrophic lateral sclerosis are mostly present in males. For schizophrenia, although there is a higher percentage of males, the balance is quite equal. What we found was that indeed there are differences between sex in these disorders, and there are differences also at the level of the treatment and response to treatment. In fact, some treatments are preferentially given to males, some others are preferentially given to females, while others can be given to males and females because they both responded to the treatment. Now, in the next few slides, I will present for each of these disorders what are the main findings, but you will see that there are some common trends. And one is that even if the patients are indeed responding to the same drug, the dosage and the timing of the response could be different. And therefore, even this should be considered when investigating or studying the disorders and when prescribing the treatment. Not only this, we also looked at the situation in the clinical trials, and over 20 years, from 2000 to 2020, we looked at what was the enrollment for the clinical studies in these patients, if there was a majority of males or females, or if both sexes were both represented. So we'll start with Alzheimer's disease, which is a neurological disorder affecting people with an onset of 65 years of age, and there is a prevalence of females. We all know the devastating effect of Alzheimer's disease, especially at cognitive levels. The males and females have a different presentation in the sense that the onset for males and also the progression of disease is more rapid. And so basically male die earlier. And so the time in which they actually show the disease is decreased, while for females, there is a prolonged time of onset, but also the cognitive phase and decline lasts longer, so they die later. And this is one of the factors why there are more females, but they live longer. Still, in both the Alzheimer is between the top 10 causes of death, so it's quite serious. And there are genes that somehow affect the frequency of the disease. So one of these is the ApoE gene. For the role of hormones, there is, like in every disease, a general protection by estrogen. And in fact, this disease starts later in age when the estrogen levels are low. Now, the majority of patients respond to both, for both patients, to acetylcholinesterase inhibitors. However, some studies say that the results are different in males and females. But for sure, we know that, for example, another treatment, which is insulin, respond a different dosage in males and females. Higher dosage insulin are good only for males. Regarding the response to the sex differences in preclinical studies, we don't have much information. However, the good news is that if you look at the graphs here, the males and females are almost equally represented. So it means that in Alzheimer's disease, the situation in terms of recruiting both males and females is not bad. The second disorder I'd like to present is Parkinson's disease, which is also a neurological disorder, but this time affects more male than female. Also in this case, the age of onset is 60. The majority of the most relevant symptoms are motor symptoms, so tremor, bradykinesia, rigidity, but there are also psychiatric symptoms. And females in general have a later onset and respond better to treatment than males. But there are other factors that show that the tendency in males is higher. One is the fact that, for example, the gene that induces masculinity, SRY, which is present on the Y chromosome, is expressed in the nigrostriatal dopaminergic system. So there is a local expression of this gene in males. And also another factor are mutation to the receptor for the estrogen level. So also in this case, the hormonal factor is pretty important. Regarding the treatment, the most successful treatment is levodopa, to which both male and female respond. However, the dosage is different, and the female in general respond better. Now, in the clinical trials, you can see that the majority of the patients enrolled are males, which is the dominant sex. And regarding the preclinical studies, there are not many data, also because there are not many, or there were not many models for Parkinson, for example, for animal studies. Now people use also other biological models to do preclinical studies in Parkinson's disease. One of these models is using induced pluripotent stem cells from patients. And in particular, in this case, the effect of sex is particularly under-considered. So the relevance of sex in Parkinson's disease is not properly addressed, either in clinical or preclinical model. And the last neurological condition that I'd like to present today is quite severe, is amyotrophic lateral sclerosis. There is a prevalence in males, and it's a severe disorder. There is actually no cure. And in fact, regarding the treatment, there are not many data regarding males and females because there are not many treatments. But we know that, for example, even in the age of onset and the presentation is quite different in males and females. This is a disorder where the motor neurons are affected. They start degenerating, and therefore they cause basically inability to contract the muscles. And this has consequences at the level of speech, but movement, limb weakness, but also ability to breathe. And in the later stage, there is also cognitive impairment. Now, for the males, they have a more severe and early onset, while the females also have a slightly difference because they have impairment in language and in memory. But there is also an anatomical difference because they have the motor neurons in males start generating from the spinal lumbar section, while for females they start earlier, I mean, in the bulbar section. So there are actually quite relevant differences in this sense. But there is a clear effect of the protection of estrogen, which could be directly addressed for females, but also in males, the lower level of testosterone are associated to a more severe presentation. And the testosterone actually synthesized starting from estrogen. So the level of testosterone are also reflecting the levels of estrogen also in males. As I said, there are not many studies done at the therapeutic level, but the majority of the recruited patients are males. There are some preclinical studies in mouse models, but the majority of these studies are done in males. So as you can see, the prevalence of males is clear, although there is a clear effect of the hormone level. So at least females should be considered and the level of hormones should be measured. So now I'm going to briefly go ahead and present the psychiatric disorders. And the first psychiatric disorders I'd like to introduce is depression, which is peculiar because depression is present in males and females, but is reported more in females. And one of the reasons is actually a social-cultural reason, is because females tend to report symptoms more frequently than males. So even if not only there are objective differences at the biological level, but there are also difference in the actual detection of patients, females versus males. So the onset is pretty much the same, which is actually could be also a very young age. And there is a protection effect of estrogen, but this could actually be linked to another factor, which is neuroimmunity. In fact, in recent years, it has been shown quite directly that higher incidence of inflammatory response are indeed connected to depression, and hormones are also protective for this reactivity. So could be a direct effect of hormones, but could be also an indirect effect via the neuroimmunity mechanism. But true is that also for treatments, they actually are different in males and females. Again, in this case, the studies are controversial, but in some cases, the males are given mostly tricyclic antidepressant or TCA, while for females, the treatment of choice is selective serotonin reuptake inhibitors. Now, here we can see also an effect of hormones because estrogen are involved in serotonin production. So it could be also an objective reason. Another treatment which is used for severe cases is ketamine. And in this case, it has been reported both in clinical and preclinical studies that the response to ketamine is different dosage-wise in males and females. And actually, in animal studies, it has been shown that prolonged ketamine treatment is pro-depressive in females. So definitely, it's worth considering both females and females when doing clinical and preclinical studies. However, in this case, also the dominant sex is most represented in the disease. In fact, more females have been used for clinical studies. The second psychiatric disorders that I'd like to mention is a disorder is schizophrenia. Which I told you already is slightly more prevalent in males. However, it's almost equal. But what is different in females is the age of onset. In fact, in males, the age of onset is pretty early, between around 20 years of age, while for females, it actually starts after 25, and there is a peak of 35, 40 years of age. So not only the onset is different, you can see from the age that there is a direct link with hormonal levels. In fact, the majority of symptoms are observed in females when there is a decay of estrogen levels and they are going, they're starting going into menopause. Also, the symptoms are different because the cognitive symptoms are more severe in males. Now, the treatment are not different type-wise. However, the response to treatment is usually better in females. And sorry, is there a question?
No, please go ahead.
Okay, thank you. But anyway, both at the preclinical and clinical levels, there is a prevalence of using males, and the studies in females are actually underpowered. So we don't really know what could be the real difference between males and females. And the last disorder, which I'd like to present today, it's again a psychiatric disorder. And it's peculiar because it's the prevalence is actually different at the childhood state and adult state. And it's attention deficit hyperactivity disorder, also called ADHD. Now, ADHD is a very disorder. Actually, 5% of children are diagnosed with ADHD in the United States, but in the prevalence is male, but the percentage of males is actually different in adults and children. The prevalence is 1 to 1.5 in adults and 1.2.5 in children. So in children, there are more male affected. Now, one of the problem in this case could be at the diagnostic stage, because the males with ADHD have a more disrupted disorder, so they're noticed more. Also, in all the psychiatric disorders, I have to say, there is a sort of stigma. So there is a tendency to ignore or give less importance to symptoms, and in some conditions, this affects more females than males. So this is true for all the psychiatric disorders. So there is also a social cultural element, but it is true that there are differences between males and females also in these disorders. For example, male tend to develop disruptive behavior, while female tend to develop anxiety and eating disorders. Now, there are treatments for both males and females. There are amphetamine, and the symptoms tend to improve with age. However, the time course of the response is different. And so, for example, it means that at the first days of treatments, there will be a response which will be equal in both sexes, but at later, several few weeks after the treatment, the females will respond better. And studies in animal models also revealed that it is possible that there is a direct effect for this disease on the ability of males to perceive the rewards. So in the system that give rewards to behavior. So this is done in rats, which are present a natural hypertension, and these are considered the model for ADHD. So we can discuss whether this is actually a good or bad model, but this model would suggest that behavioral therapies, at least for males, could improve the response to treatment. But for example, also in this case, especially at the clinical level, there is a higher prevalence of enrollment of males. So we don't really know about the females, both for the sociocultural situations, for the objective differences, or the studies, which again tend to enroll the majority of males. So overall, I showed you the differences, and I'd like to say that also at the preclinical level, the tendency is to use males. This is true especially for studies in rodents, which are the most frequent, but also studies in cells derived from patients, which is from a few years one of the choice model for the study of human conditions. In this case, the derivation and the sex variability is even less considered than for animal studies. I can tell you that for animal studies, one big problem is the actual variability, because the results in females are way more variable, and probably this is strictly correlated with the hormonal level. So I think, like many other colleagues, think that it's important also to measure the hormonal levels while doing studies in female, because they can be influencing the results. So, but overall, if we look ahead, these are disorders very complex. There is not only one explanation. Hormones are not the only level, but definitely they need to be considered and measured together with the other parameters in order to understand better the disorders. But it is important to consider the biological variable, because it could make a difference in the treatment of choice, in both the level of dosage, but also at the level of timeline of the treatment. And also, as we have seen, for example, for ADHD, additional therapies could be associated to the pharmacological therapies for a better outcome. And the last thing I'd like to say is that we have also to keep in mind that the brain and body are strictly related. So we can't ignore parameters that are normally regulated in the body, like, for example, the levels of cytokines, the level of hormones, even nutrition, when considering brain disorders, because this could actually impact the severity of the presentation, the response to treatment. And so to properly understand the disorders and identify the proper treatment, they need to be considered. And in any case, the tendency of using mostly the dominant sex, both at the preclinical and clinical level, is not helping with our understanding. So now more and more studies are actually addressing the sex variable, but there's work to be done. So with the last slides, I'd like to thank the students that with me did this study. The study is published in a review that was published last year. And I welcome questions. I renew my thanks to the organization for inviting me to this symposium. And I'm ready to take questions. Thank you.
Thank you very much for the invitation to be here today. Unfortunately, I cannot be here in person, but of course, I'm very happy to join you and be able to talk a little bit about implementational aspects. I'm sure you've heard a lot of marvelous new things about research. You've talked quite a bit about knowledge production, about innovations. And today I would like to give a slightly different perspective, which is how do you bring all of this into practice and which organizational structures can help you in trying to make this more of an institutionalized practice. So something that can change in your organization so that sex and gender sensitive research and clinical work can become the norm and the standard. And as you've seen, the title of my talk today is Opportunities for Structural Implementation of Sex and Gender-Sensitive Research in Medicine. I will first start briefly and say 2 words about why do we focus on implementation at all, and in how far do sex and especially gender aspects play a role in implementation? Is it important or not? And in how far is it relevant? Then I will say a few things about the different levels of institutional implementation. There are different degrees and different levels where you can do implementation at the macro level, which is really on a broad and maybe even international context. At the micro level, really in the depth of your curriculum maybe. And then what happens at the meso level? So the meso level is really your organizational structure. So it's a bit higher than your curriculum, but it is not at the international level yet. So we'll say a few words about what happens at the macro and the micro level, just giving a few examples of how things have already changed and in how far they're helping us and what we can learn from what has happened. And then I will focus on the meso level. What can organizations really do to achieve more thorough implementation? Now, I think it's important to state this first because this is a fundamental aspect that we're dealing with. Sex and gender-sensitive research is an innovation. And that means it's connected to change, it is something we haven't done before, and it also means that is something that we need to bring into existing systems. But it is per se an innovation. And sometimes innovations have a very successful story, sometimes they have a less successful story, and that has to do with a lot of different factors. What you see here is a list of characteristics that innovations have that make them actually innovations rather than just something people came up with. And as you can see here, when you go through these lists, there's a number of questions that can help you understand your innovation and how far it connects with existing structures. So I'm just going to name a few here in the beginning. The first one is, well, does your innovation provide a relative advantage? So if you do it, does it make things better for at least some of the people in the system? Not necessarily for everybody, but does it bring an advantage over what we're doing now? If there is no possible advantage, people will not pick it up. The second question is it compatible with existing structures? So if you want to implement something, you want to implement an innovation, does it fit into how you're doing things, into how your practices work? The third one is, for example, is it difficult? How complex is it? Is it perceived as something that is not as easy by people, and hence will they maybe not do it? As you can see, I'm talking about the first 3. I'm not going to mention all of these, but all of these different aspects of an innovation will make it harder or easier for the implementation afterwards. And you can take sex and gender sensitive research or sex and gender sensitive specific clinical practices and look at in how far do they fit in this. Of course, it can also help you and find measures to actually do it. The second question that I had was like, well, in how far do sex and gender play a role when we deal with implementation? And what I'm showing you here is by now a quite trialed and tested model that shows that there's different degrees of sex and gender sensitivity in the implementational processes we do. Also, for example, the WHO, the World Health Organization, uses this model at times. And what in principle it just shows you is that there's really different levels that can take gender into account when you innovate something or when you implement something. The first level, and this is of course what we hope we will get rid of, is when it is completely unequal, and not only what we're implementing in terms of innovation is unequal, it actually perpetuates gender inequality. So it might even make things worse. So this is the first level. The second one is gender ignorant. That is, well, yeah, there are gender differences. We're not making them worse, but we're also not doing anything about them. So this is an innovation that doesn't take gender into account at all. The next level is gender sensitive. So we acknowledge that there are gender inequalities. We say, for example, well, overall, when we look at cancer mortality, apart from very few exceptions, men die more often of cancer than women. Now that's gender sensitive, but we don't change anything by this. It just acknowledges the fact that there is a difference. The next step is gender specific. It is when you start developing some programs or some interventions that are specific for women and men. You might not change the overall system of care, but you do something that's specific for women, like a women's clinic, for example, or something that's specific for men, a prevention program that is designed for men. So you're acknowledging it, you're taking it into account, but it is a sort of add-on that you're doing. And then the last level is the gender transformative. The gender transformative is the level where you acknowledge that there are sex differences or gender differences, and you try to work at the origin of the difference. You're not just making a program specific for women or men. You're actually trying to understand, where do these differences come from, and can we work on the root causes? Of course, this is the most complex to implement. It's also the most difficult to achieve, but it is overall the one that will change the system the most. Now, as I said before, implementing sex and gender sensitive medicine is an innovation, and implementing innovations requires change. And as most of you know, not everybody likes change. So what do we do with this? How can we work with this? Now, this is a picture that is quite well known. Initially, it was developed by Rogers in the 70s to show how the uptake of innovation works. So this goes for a number of things. This model is used until today very often to describe how the the taking up of an innovation actually works. And you see there's different degrees and different groups. You have initially you have a group of innovators. So these are the people that first have the idea, that start thinking about it, and that want to do something new. Then you have the early adopters. These are the people who start working on this relatively in the beginning. They're not the people that are told, oh, you're crazy, you want to do something that makes no sense anymore. But they're also not a large majority. Then we start having an early majority. And then we start seeing that everybody else is also picking it up. So this kind of procedure works for innovations in food. This was actually used to identify how farmers would take up different new forms of wheat. But it also goes for, I don't know, the iPhone or the electric cars. So really, most innovations follow this path. And you can use this to describe sex and gender sensitive implementation as well. I would argue that we're somewhere here between early adopters and early majority. We're not like 3 people anymore doing something that everybody thinks is crazy, but we already have a starting critical mass like many of the people who are here today, but we're not really at the majority level yet. We're somewhere here in between. Ideally, at the end, when everybody has picked this up, we would have an institutionalization. So it would be normal and it would be practice to do sex and gender sensitive research or sex and gender clinical work. Now, of course, along this way, there's drivers and there's hurdles. So there's things that help you and things that make the whole thing a bit more complicated. As I said before, there's different layers we can look at, and we can learn from them. We have quite some literature and a lot of things that have been happening at the macro level. Think about funding institutions, and I'll just say 2 words about this in the next slide. So things that happen at the national or even international level that change the broad picture. Then we have the micro level. What happens, for example, within singular curricula? So, or what happens really at the level of the single school, but not even at the organizational level, but really at the practice level. Who does something maybe in their specific clinic, but it is not something that is shared with the whole organization. And then there's the meso level. So the meso level is actually between the micro and the macro, and that's the institutional implementation at the organizational level. So what happens in the organization that can help you? And really the question I have here is what policies or what practices can be implemented within a biomedical organization to purposefully build awareness, knowledge, and a critical mass of people that can do this. When we look at the macro level, you're quite aware of this, I'm sure. There's a lot of international and national, also in part, funding agencies that are starting to request people to look into sex and gender when they do research. We have the European Commission, the Canadian Institutes of Health Research, the NIH in the US, and many other funding organizations who basically ask their grantees to look at sex and gender to increase the scientific quality, the reproducibility, and the generalizability of their work. So this is really a macro level change, which forces the system to start thinking about this. In addition to that, also scientific publishing has started picking up sex and gender a lot more. Many journals, many large publishing houses, Elsevier, Springer Nature, while a lot of other large publishing groups have started recommending that researchers that submit work to their outlets actually consider the sex and gender equity in research guidelines, the SAGE guidelines. So there is also, from the publishing houses, much more pressure to do this. So these are both at the macro level. When we look at the micro level, and we can look, for example, at teaching, there's quite a few examples of what happens. There's different degrees of implementation in teaching. We have a few medical schools that manage to integrate it systematically into mandatory teaching. We have a few that do vocational teaching, so there's some additional courses that deal with this, and sometimes there's just lecture series, but at least the students are exposed to it. And even what we're doing today is really something that exposes researchers and clinicians to the topic. There's a few also systematic approaches that have been described in literature. I'm showing you one here that we did in Berlin at Charité when I was there years ago. It just shows how an implementation at the micro level. Many times it's really a combination. So we know quite well how it actually works at the curriculum level. We're not always able to implement it fully, but we have a very good understanding by now of how it works. Ideally, you want some top-down pressure where you have experts, either internally or externally, who give specific lectures, who bring in this knowledge, who activate their colleagues. Then you want, ideally, requests by students, by PhD students, by medical students. Sometimes they even self-organize and invite lecturers to give some lectures at their medical faculty to teach people, in order to generate pressure from above and pressure from below, so that even in the general lectures of our colleagues, they start picking this up. So this is quite well documented. But now the question is, what happens at the meso level? So in between those two levels, what can organizations do and what is success? When we look at this, there's really many different aspects that come together. So one is the characteristic of the innovation, which I mentioned in the beginning. How is sex and gender sensitive medicine perceived, or sex and gender sensitive research? Does it connect with what you're doing? Does it not connect? Is it difficult to implement, and so on? The second part is the institutional resistance, potentially. Maybe your organization is not ready or not willing to do this. Where does this come from, and how can you work with it? Then the personal experience of the people who might have to implement this. Did they try to implement innovations before and maybe they were not successful? Maybe it was a frustrating experience. They don't want to do it again. They don't want to necessarily change. So in how far do people's personal experiences play a role? And of of course, there's peer perception. What do your colleagues think if you do this? Do they think it's a good idea? Do they think it's innovative and really nice that you're doing this? Or do they think, well, something we might not need? So all of these come together, which translates into this. There's basically barriers to organizational implementation and helpful factors. So I'll start with the barriers and then I'll move on to the helpful factors. Now, barriers are similar in this case to many other cases. There are similar structures whenever you try to change an organization. So first of all, in many cases, people are reluctant to change. As I said initially, a lot of people like the structures they are, even if they're not perfect, but they're used to them. They don't want to change them. They don't want to have to do something new. So you have to work against that and show that what you're proposing might make things better or easier or more valuable for patients. There is in every organization competition for power, for funding, for visibility, for agency, the ability to change things. So these are aspects that are very personal that people perceive at the personal level, but they're very, very resistant and they make people very resilient to change. What you're proposing might not align with the priorities of your organization. Maybe your organization doesn't think this is important. People in your organization don't think it's important, and it is difficult because it doesn't align with the priorities. Then maybe you have to see how you could make it align. There's local power constellations. And of course, if the people that are doing it are not the most powerful, the most visible, there is not a lot of them, all of this makes it difficult. Of course, there's also general things. There's insecurities about the topic of sex and gender. Is this really a research topic? Is this, how do I talk about this? How do I do this? I haven't been taught this before. It's something new. How should I handle this? And then in the last, there's also still the perception that sex and gender sensitive medicine is a political topic. It's an emancipatory topic. It's only related to women, and many people still have issues with that. Now, what is helpful? I'm going to go through a number of things that we are doing at the medical faculty at the University of Bielefeld, where I work in Germany, where we're actually building up a new medical faculty. And so with the help of many colleagues, with a successful deanery, and with the Equal Opportunities Officer, we have put in place a number of measures. And I'm not going to tell you specifically just all of the things we are doing. I'm trying to explain these in a much broader way so it might fit for your organization as well. So what have we been doing? What have my colleagues who have started before I even started there already been doing? Well, first of all, you want to secure top-down support. So you can implement change at an organizational level if you don't have top-down support, but it is really difficult. Because of course, most of our organizations, especially in medicine, are quite hierarchical. They're built like pyramids. And if you don't have the support from the top, it is really difficult to change things at the bottom. It's not impossible, but it is more difficult. So if you can ensure some form of top-down support, your work will be much easier. What people don't think about sometimes is that it doesn't necessarily have to be within your organization. I'm very lucky because we have a very supportive dean. She really thinks this is an important subject, and so there is a moral and also practical support. That's not a given, but you don't necessarily need to have that. Sometimes it's helpful to have help outside of the organization. And so think about your local municipality who might actually like the topic of diversity, of sex and gender sensitivity. Think about politicians, chaperones, sometimes celebrity, especially in the United States. You have some examples of sex and gender sensitive research organizations supported by famous people, Barbara Streisand, Laura Bush, who have supported some of these endeavors and organizations. Now, that also means that depending on where you are, this outside top-down support can look different, but it can also be outside of your organization. And sometimes it's even more powerful than within your organization. The second point is build capacity. You need a number of people doing this. Of course, you can do it by yourself, but it will be lonely, and at a certain point, you're going to burn out. You need a network of people that can work with you. Maybe they're already there, and you just need to find them. Or maybe you can also start building up such a network. Find people that could be interested, work together with them. And what you do is you will increase the visibility of the topic and you will build interdisciplinary collaborations. Ideally, you need a person in charge of the implementation part and of the practical part within the organization. That doesn't even have to be a researcher. It can also be somebody with another function. It can be someone in your team, but there can be a specific change agents within the organization. And sometimes in a number of countries, you have a DEI, a diversity, equity, and inclusion office that can help you with that. What they do is they mostly focus on the structural implementation. And even if you don't have an office, you can have a person that you designate, at least with part of their hours, to work on the implementation in existing processes. Remember when at the beginning I said, does the innovation fit within how the organization works? Ideally, you want to make sure that what you try to do connects with what the organization is used to, with what you're already doing. Then, of course, you need to provide training measures to build capacity. For example, what we're doing today, but it can be many different things. It can be PhD trainings, resident training, grand rounds, especially professional training. There's a number of things that you have to do mandatory. There's a number of mandatory trainings that we have to repeat on a regular basis. So, for example, think about safety updates. You can connect this to sex and gender, for example, different exposure, different reactivity, and different risk. Prevention of discrimination trainings, for example, can you incorporate it in there? So if there is a way to attach it to any mandatory training, you really have a winner because people need to go and they might hear about the subject for the first time. You want to monitor your results. This is something that doesn't happen as structurally. Ideally, you want a probably disappointing baseline data set. What is happening in your organization? How do the people structures look like? But how does the research look like? How is the output? Does anybody in your organization do sex and gender sensitive research? Is there any publications? Is there any grants? And then as you start working on this and as you start building capacity and maybe things start slowly moving, monitor them. Even little gains at the beginning will motivate people to do that. And over time, you want to document how your measures have actually worked and also see what worked and what didn't. And then you want to hold people accountable. This is the other thing. There are sometimes institutional promises and assurances that are being made. Also, just because you keep asking, at a certain point, people want you to maybe stop asking. But if these things are being made, follow up with them. And this is why you need the monitoring as well. Because if any form of assurance will come in any possible form, and many organizations do that, even just to silence you, you can follow up on that. And this is why you need the monitoring results. If you put all of those together at different levels, you will see that it is possible to here and there connect to existing procedures and actually build an environment that then will foster new development of knowledge and help people in integrating that. And then overall, as I said, you can target these 4 different areas. What I just showed you in terms of possible solution, target all 4 of them. And this might help you in over time building a structure, an organizational structure that will help people grow and that will help institutionalize sex and gender sensitive research and clinical practice. And with that, I thank you very much for your attention. It was a pleasure being with you today, and I wish you a very, very successful and enlightening continuation of the conference. Thank you.